Good evening, everyone. I'm Sunny Shell, and here's my co-host, Jenna. Hey,
Hi,
Jenna.
everybody. This is exciting.
So it is. This is the Crucible on the Promethean Secular Frontier, where we discuss science, philosophy, and reason from a secular perspective. And I'm really excited that you have agreed to co-host tonight.
Oh, absolutely. I finally managed to be off work and rush here, and I could not miss this. I think this is a very, very important topic discussion, and we just have great hosts with us tonight. So, yeah, I'm looking forward to it.
I am too, absolutely. So without further ado, I want to go ahead and introduce our guests. The first one I want to introduce is Charlotte. She's a nurse living in Minnesota. She's been working in healthcare since 2003, and 15 of those years have been in mental health care. So, welcome, Charlotte.
Thank you very much. I'm happy to be here.
We're really happy to have you here. Next, we have Hannah, and Hannah is an award-winning journalist managing a psychology health initiative, and she studies childhood resiliency and trauma, which is right up my alley. So welcome, Hannah.
Thank you. So happy to be here.
Great. Thank you so much for coming along on this journey with us tonight. And finally, we have Dr. Snow. Dr. Snow is a family medicine physician who is also serving in the military. So thank you for your service and welcome.
Thank you. I'm so happy to be here.
So tonight we are talking about how healthcare fails those with trauma. And we talked about this kind of behind the scenes a little bit. The best place to start is to talk about what is trauma-informed healthcare. What does that mean? What does that look like? How do we achieve that? So let's start out with what is trauma-informed healthcare?
Yeah, and I know just to give a basic plain definition of it, I did pull up just a little snippet. And as myself, I am a nurse for roughly about 8 years. So anything surrounding the mental health or the trauma-inducing healthcare or anything surrounding that practice, I have little basic history with. So basically what I pulled as far as trauma-informed care is an approach into engaging with people with histories of trauma that recognizes the presence of trauma symptoms and also for a healthcare provider to recognize those signs as well and acknowledges the role that trauma has played in their patients' lives. If that's pretty much a nice kind of slate that we can start off, then by all means.
All right. So thank you very much, Jenna. This is something that's very close to my heart because, as many of you know, I work with child abuse victims and trauma, especially if you look at adverse childhood experiences across the lifespan. We know through some of these longitudinal studies, like the trauma study through the Kaiser Institute, that adverse childhood experiences actually have an impact on your long-term health, like obesity, stroke, all of those different types of things. It even has impacts in economics with higher rates of poverty and those type of things. So this is such an important topic, and I'm really interested in really seeing what it would mean for us to have that trauma-informed healthcare. Is there a difference between the healthcare we receive just when we go to our primary care physician versus having some healthcare that is actually trauma-informed?
Yeah, so we had been talking about this kind of before the show, and Charlotte and I had very similar practices, it sounds like. If you want to come work with me, let me know. You don't want to work with me, you're fine. So the big thing for me with trauma-informed, so I work in a military population, very high levels of trauma, very different sorts, right? Is about giving power back to the patient, because for so many people who have had traumatic experiences, a lot of that is sometimes that loss of power or control, and that's really hard. So it can be something like knocking and saying, "May I come in?" and actually waiting for the patient to say yes before you come in the door. It's telling the patient what to expect of an exam or an encounter before it happens. I help teach medical students, and one of the things that I hammer all the time is tell the patient before you touch them. You don't want to be saying, I'm going to examine your thyroid, and you're mashing on their neck as you're doing it, right?
Right.
Because that really doesn't give them a chance to go. And that kind of goes with, Charlotte, I'll let you kind of go further into kind of the consent discussion that we had, because I thought you had some really good points.
Okay, sure. Yeah, so I mean, I work as a nurse. I do direct bedside nursing patient care. So I'm doing assessments all day long when I'm on my shift. And I always make a point of asking before I do my assessment, like even something as simple as like listening to their heart or lungs. And I've had so many patients sort of react with surprise and like kind of joking, well, what if I say no? I said, then I wouldn't do it. Like it's just such a rare occurrence for them. I also had a situation where I had a nursing student with me and overheard her instructor telling her that you don't ask the patient if you can do an assessment because they're not supposed to refuse. And it's like, no, the patient always has the right to refuse any assessment, any procedure, anything. It's their body. And I know that often we get very, I think, caught up in our jobs. We got to get through the assessment, got to do what we got to do, got to, figure out what's going on with the patient. But it's still very important to remember it's their body and they're in charge of it. As that's very important to me as both a nurse and a mom, teaching my children the same thing, that they're in charge of their body. Nobody has to do anything to it or can do anything to it without their consent.
Absolutely.
Yeah, giving consent back in healthcare is a big thing, because I'm sure you've experienced this where, someone comes in, starts asking you a bunch of questions, and they just start doing stuff, and you kind of have no idea, like, whoa, what is going on here? I do, as family medicine, one of the things that I'm really passionate about is, women's healthcare. When I say women, I understand it doesn't include, like, they're not all people with uteruses are women and not all people with penises are men, but just to use that kind of generic term. So women's healthcare, something I'm really passionate about. And so whenever I do PAPs or IUD insertions or any sort of pelvic exam, I always, ask the patient, have you had this before? Do you know what everything is? And if they say no, I will show them all the tools, all the steps. I explain what it's for. I let them see it. And then when I'm doing my, pelvic exam, obviously I'm down there. The patient can't really see me. I do everything I can to make them comfortable. I'm like, do you want to sit up? What can we do to make you more comfortable here? I turn down the lights so that way the overhead fluorescent lights aren't blinding them, because it's kind of like the sun. And then I tell them what I'm doing. I'm like, okay, now I'm inserting the speculum. You're going to feel pressure and cold. You're going to hear a sound. If it's too much, let me know and I'll stop. Now I'm getting this brush and it's going all around your cervix. You might feel some pressure, or some people find it uncomfortable. Now I'm pulling it out. Now I'm doing this, right? And a lot of patients have told me that they've never had anyone tell them what they were doing down there. And that's part of trauma-informed care. The patient doesn't have to disclose to me their trauma. And a lot of times people don't even realize some things are traumatic, right? Like we can internalize all that trauma in like a hard little acorn until you just are like, oh, that's normal. It's not normal.
Yes,
Right.
absolutely. And that aspect of the loss of agency and the loss of autonomy when a trauma occurs really is pivotal to how it affects someone, because they had their autonomy taken away in that moment of trauma. So to give it back to them is so pivotal, because when that happens, especially when it happens in childhood, they have this dysregulation of their nervous system that could be impacting the lifespan, or even if it was something earlier or later in life that occurred, they have this major disruption of their nervous system. And so they get into this survival mode where they're constantly on high alert. And so by you walking through the process step by step, puts the autonomy, puts the agency and the control back on them, where they know that they can withdraw consent at any time and they're kept up to date on what is happening step by step. And that is so powerful, because like I said, that is one of the key signatures of trauma, is when that agency is taken away and their control is lost. So that is so powerful to help them with that dysregulated nervous system.
That's so true. I know with the work that we do, when a child makes an outcry of abuse, or if someone has made an allegation of abuse against a child, they come to our center. We do a forensic interview, and we also do a child medical evaluation. And that medical evaluation is not invasive in the sense that we don't use a speculum. We take pictures of any trauma. but we don't stick anything into any body parts. At the same time, you have children who have been traumatized, and now you're looking at their private parts. And so we are very, very careful about how we do that and make sure that we are being trauma informed and that we are explaining things. And it's interesting because the parent, the usually the mother, but it could be a grandmother or an aunt, may be in the room with them at the time. Not always, but sometimes. They tend to be very surprised that we're being as cognizant of that trauma as we are, because they have not experienced that.
Mm-hmm.
They've never experienced that. They're used to, well, just take a deep breath. This might feel uncomfortable. And that's the extent. Or there'll be someone else in the room with you. You know, there'll be a nurse here. So it won't just be me. And that's the level, that's all that we get. And so they are very surprised. And they've commented that they wish that they would receive that kind of care. Many of the caregivers of the children that we serve are victims of abuse themselves. I mean, if you think about it, 1 in 6 girls and 1 in 10 boys experience trauma before their 18th birthday. Mm-hmm. So that means there's a hell of a lot of us adults who have experienced childhood maltreatment. And even if you haven't as a child, as an adult, there's a lot of adult maltreatment that happens. So there's a lot of traumatized people out there, and we need to be more aware of how we are treating them in healthcare and any other service fields. Yes. So what are your experiences with childhood trauma in particular? I'm just curious. Any of you with childhood trauma?
Like us, like personally or professionally?
No, I'm sorry. I meant professionally. As far as how you have dealt with childhood trauma in your professional career.
Well, I mean, I work in mental health care. Now, I don't work with a pediatric population. I did sometimes go to the adolescent psych unit. That wasn't my primary unit that I worked on. But of course, I mean, we all know things that happen in childhood do tend to follow, throughout their lives. And I definitely noticed people who, like adults who had a history of trauma, also tended to have more comorbidities. Like they were on more medications for more medical issues, far and away, even more than people who would have what we would maybe consider a more serious psychiatric illness, like bipolar or schizophrenia, would not have as many co-occurring disorders as somebody with a diagnosis of PTSD, which usually went hand in hand with like depression and or anxiety, sometimes chemical dependency, because that's kind of how those things work.
Right. Absolutely. In fact, the ACEs study came about because of so many, they were actually looking at obesity, and they found that so many people who are struggling with obesity have had these adverse childhood experiences. So absolutely. It's amazing how it kind of crosses over into all these other areas.
Well, and if you understand the biology behind it, it does make a lot of sense, because our body's response to stress is to release cortisol, which is basically like sugar, because it's getting ready. It's like going back to when we were like living in caves or in fields or whatever, and we had to watch out for predators. And so stress meant if you were feeling stressed, you had to escape from the tiger or the lion or, whatever threat was coming at you. And we don't face those issues now in our society, but our body still has the same biological response. And when you have cortisol being released into your system chronically, then it's going to lead to all kinds of conditions like insulin resistance and diabetes and obesity and things like that. I mean, our bodies aren't built to deal with that chronically.
Right.
No. You're totally right. So when you're under the chronic stress, it's the sympathetic nervous system, which is the fight or flight system. So just like you said, like there's cortisol, your body is shunting blood away from certain parts and to other parts, so that way you could escape, versus the parasympathetic, which is the rest and digest system, which is where the blood all comes to the middle so you can sleep and digest food and poop and do all the things you're supposed to do. If you're constantly stressed, those systems are all completely dysregulated because of cortisol. It's totally right.
Yeah. I know. And I'm sorry.
No, go ahead.
I know I don't work closely with children, mostly mainly adults. I work in a excuse me, health education department that under my specialty, I assist with management of patients seeking bariatric surgery. And so they must go through a program before being seen by a surgeon, and it's required for all participants to be assigned a behaviorist to have this one-on-one evaluation, usually in person. Now it's been like video consults over the phone. But all too often, of course, with dealing with this obese population of patients, quite a few are come across during those evaluations of having some type of, traumatic experience stemming from, adolescence or teenage years. And a lot of that has, pretty much ran into them being overweight in the first place. And so their mindset, unfortunately, is, oh, I'm going to get this easy fix. This will fix my trauma now, the quickest way. But unfortunately, we have to hold them back a little bit so they can still be readdressed and make sure that even though, yes, you could be successful with this surgical procedure, but you need to understand that this is not a quick fix. You have to work at this lifestyle change and make the necessary adjustments to your life, because this can only just exacerbate your trauma even more if you're not making that lifestyle change now, if you're not understanding the psychological and behavioral changes after or post bariatric surgery. So having those specialties in place, seeing those evaluations for myself, and I'm like, you want to fight for them. You want for them to be successful and get what they want ultimately, but you have to, pull them back and say, we really need to address this first.
Yeah. Well, and even above and beyond obviously, trauma has such a huge impact, and we're just starting. Like, I've been reading so many fascinating articles. We're just really starting to tap into the the microbiome, like our gut bacteria, and how that affects our mental health, and vice versa. Like, it's a feedback loop, right? So if you're stressed and depressed, you're not digesting as well, and so then you're eating lower quality foods possibly, and it just sort of, it gets into this cycle, right? Our gut bacteria affects our mental health, which affects our gut bacteria, and on and on.
I just want to say my mental health is improved by seeing Dr. Snow's cat. Anytime I can.
Lola has some opinions.
Absolutely adorable.
So I was going to say, so I've seen a lot of different spectrums. So in undergrad, I was a patient advocate for the local shelter. So if a client was in kind of the immediate aftermath of a traumatic event, they would call the shelter and they would send an advocate, and we would help them with community resources. These are your rights. This is what you have access to. We can help get you, if you're seeking shelter, we can help take care of you. We can take care of your kids. So that was really my first introduction to trauma, which was very, very powerful experiences. And then as a physician in family medicine, we see kind of everything. And in my training, in the pediatric ER, you would be there with a patient who was, waiting for their sexual assault exam. And sometimes I would be the only female on the shift, and I was like, no, I will take it. No one will take this. I will take this patient. I will take mine. And then otherwise, on the kind of the other side in clinic, I had several patients who, in training, and especially now in my, now that I'm a grown-up doctor, that I take care of sort of after these events. They've had their sexual assault exam. Now what we're doing is we're coordinating with mental health. We're getting them on medications to decrease all that cortisol so they can sleep. Doing all that sort of long-term stuff. And I always tell patients, I'm like, the medication isn't going to make the trauma go away, but it's going to give you sort of the mental and emotional spoons to start to deal with it. Because I don't know if y'all have ever had this, but like after like a really good therapy session, you have just like this like hangover, like emotional hangover. You're totally drained and you're like, I can't do anything the rest of the day. Um, so I'm hoping, with patients that the medication gives them the ability to handle that emotional hangover as they process their traumas. And some of this stuff is stuff they've never talked about with anybody.
Yeah, absolutely. I wanted to kind of highlight what Kathy had said, creatively Kathy had said, because I think it goes right along with what we're talking about. I'm going to highlight it again. She said that her GP and her therapist are now coordinating care. And I think that is extremely important and something that doesn't happen very often. But like you're talking about with all of these different physiological and biological processes that we see as a result of trauma, we also need to take into consideration the mental health care, working with a psychologist or a psychiatrist, and having that coordinated care. Do you guys see that in your own practices?
I mean, I work in a hospital, which means when you go to the ER and you get admitted, you are assigned a hospitalist, somebody who just works in the hospital, who has never met you before, who like all they know from you is whatever's in the ER report, generally speaking. And if you're, they may be thorough when they come and talk to you, but I don't know that they generally touch on trauma necessarily. They just want to know, why are you in the hospital with us today and what's going on, and how can we fix it? One of my eternal frustrations is how often it's just other issues well, you can follow up on that outpatient. And I do think too, like one of the biggest mistakes that we have made in Western medicine in general is just this separation of mental health and physical health, because it's all intertwined. Like everything impacts everything else, and anything that's mental health related tends to be sort of like pushed off, relegated as not important. Like take, for example, so we're all familiar with the term psychosomatic, right?
Mm-hmm.
In the cultural understanding, something that's psychosomatic, it's all in your head, it's not real. That is not what the word actually means. It actually is a reflection on the impact that your mental health has on your physical health. So it is the exact opposite meaning as what we've come to understand it as, because it really does. It's so intertwined.
Yes.
And it needs to be a bigger piece of what we do as healthcare
Absolutely
workers.
Yes, that's so true. So within trauma, I work with a foundation who we specifically study facial pain. Trigeminal neuralgia, it's a severe neuropathic facial pain that is absolutely diabolical. And a lot of the people who are seeking care for this, they're going to their neurologist and their neurosurgeon or a dentist, which they need to go to for that portion of the care. But as someone who is a child of someone who has this disorder, I grew up with one of my parents having this disorder. So I know it from that personal point of view, and then also professionally as someone who works with these patients and who studies trauma, which pain psychology falls under that umbrella in part. I find that so often they are so focused on their physical symptoms of trying to exacerbate this horrifying pain that they forget about their mental health symptoms, and that often results in them taking their own life. There's a very high suicide rate connected with this. And so I see that extreme side of when you are only targeting the physical symptoms and you forget the mental health systems, just how tragic it can become. And so having that trauma-informed care, having physicians, and, I think, what if one of my father's neurologists had referred him to a psychologist, how different could his life be? And I see that with so many people who I work with who have this disorder or similar ones, specifically within pain, but really any disorder. If you become so focused on just the physical symptoms, you do a major disservice to the patient that can have very detrimental results.
That's yes, absolutely. So for folks listening or watching, one thing that you could look for in a physician or anything like that is to be asked, how does this impact you? How does this affect you? Because a lot of times people don't get asked that. You get asked, where does it hurt? How long does it hurt? Does it move anywhere? What kind of does it feel like? What makes it better? What makes it worse? Um, and we kind of forget, how does this impact you? So like, and I use templates in our medical record because I will 100% forget things, and it helps you not forget things. But so one of my questions in almost all of my templates is this keeping you from doing things you want to do? What is your job? What are your hobbies? Because if I can guess, someone's coming to me for something, and then I can see what their job is, I can see what their hobbies is, it helps me kind of understand how these things impact them in a more contextual way. So that way I can see the patient as not just someone here with, depression or whatever. I can see them in a more, because we're all whole people, right? And one thing that the military does kind of well is a lot of the military treatment facilities have integrated behavioral health in the clinic. So I do work closely with my patients' therapists. We have a telepsychiatrist who I do work closely with and I coordinate care with. We kind of bounce things off. He's like, hey, have you ever checked their thyroid? I don't really deal with that, but just a thought. I'm like, sure, I'll check the thyroid. That's fine. So that is kind of nice. But yeah, it's totally frustrating when I get a discharge note and I'm like, what on earth is this? And hospitalists have a hard job too, though, right? Because they're only with that patient for that one little period of time. Mm-hmm. So it's definitely hard. It's back in the old days when primary care people would go see their own patients who were admitted, then they knew them. Right. But our system doesn't work that way anymore. And sometimes I wish it did, but I also really like sleeping.
It can be tough. Yes. Yeah. I know within my department, I have just one provider that coordinates weight management counseling for either weight loss medication, help post-bariatric surgery care, just any way, shape, or form she can provide that one-on-one assistance with whatever to help assist them either get to weight loss surgery or the care and management thereafter if they see that their weight is creeping back up. One of the things that she strives for is at the initial consult is to integrate the mental health questionnaire, the PHQ-9, or the personal health questionnaire, where she identifies their level of depression, identifies the level of pretty much their mental health status of where they are now, and also involving in this long questionnaire, what's your eating habits? What do you do on a daily basis? Things to identify what that person is and how they're like outside of the office into the real world. What do you do? And where can we identify instances within your life to make healthy changes so you can be successful, including how you are mentally in your state and how you feel at your current weight and where you see yourself after.
Yeah, I think what I find interesting is in a lot of other areas, there's a move towards more multidisciplinary type approaches, but not necessarily in mainstream healthcare. And I think that's the big problem that we're seeing. And I'm wondering if I know that in my field, it took a while before the investigative teams kind of all agreed to work together. It was really hard. We're siloed. We kind of hold on to our expertise and our stuff really tightly because it's us. And what are you going to do with it? If I share it, what are you going to do with it? And how is this going to, are you going to undermine me in some way? And it took a while before people started realizing that when you break down those silos, we actually do better, not just for the cases themselves, but for the clients themselves or the patients themselves. Mm-hmm. And it seems to me that we kind of need to work on that in our medical and mental health fields. I think that there is sometimes this, even just taking mental health care out of it, if you look at just healthcare itself, it's sometimes difficult to get a referral for other healthcare. Like if you go to your primary care physician and you say, I really think I need to see an endocrinologist. Well, really, why? Why do you think that? I'm the doctor. I don't think you need that. It's like, no, I really do. I really do think I need that. I'd like to see a specialist. And it's like, you have to fight just to be able to do that, let alone the mental health care aspect, which a lot of times is considered more of the softer science. And
Right.
so am I making sense with what I'm saying here? I mean,
Absolutely.
Oh, yeah.
I mean, I can speak in. I mean, even working in a hospital setting, it's more multidisciplinary than like in a clinic setting because all of the disciplines are right there. But even then, like, so you have the hospitalist that's like making all the referrals out. So let's say they consult the neurologist and the urologist and the endocrinologist and all of those people. Those doctors don't necessarily talk to each other. Like they just sort of stop by and they talk to the patient and then they write their note and then they go about and they see their next patient. So even when you have a multidisciplinary approach right now in a hospital setting where everybody's at least in the same building, not everybody's necessarily on the same wavelength. And I don't know how many times I've been like playing telephone with the doctors because the one doctor would be like, can you contact the surgeon and ask them that they really want this? And it's like, why don't you talk to them yourself and have a conversation? Because maybe that would go further and faster. And in most cases, I don't think like psychiatry doesn't generally get consulted in the hospital unless it's a real obvious thing, like they're there, because of a suicide attempt or they're a behavioral problem. Essentially, like if they're disruptive, that's then psychiatry gets consulted because the staff is having trouble managing whatever this patient is going through, which is manifesting as behavior. So yeah, I've actually asked to have patients' home medications represcribed, which primarily the one I was concerned about was an antidepressant, which you're not supposed to stop abruptly, and the hospitalist told me that was not an important medication.
Well, I will speak to the asking your primary for specialist referrals. This is something I run into all the time. So the good news about primary care is that we can handle a lot of things, and specialists are for people who are outside. I describe it as like a sandbox. I know my sandbox. I know what I can do. If you're worried about your thyroid, I can check your thyroid. If it's a little wonky, I can treat it. The specialists don't need to see every garden variety hypothyroid. They don't need to see every person with asthma because then when someone who truly needs that specialist level of care, they can't access the care they need because the specialist is gobbled up with all these people that I could be managing. I do understand how it is frustrating to be like, no, I really feel like I need to see that. And that's where that dialogue needs to be happening. Instead of being shut down like, oh, I'm the big bad doctor I know. What are your concerns that you want to see an endocrinologist? Okay, what can we manage here at this level so that way we can get you feeling comfortable? Here's my reasoning. So a lot of times, I'll even look up, I'm like, okay, so you're worried you have this. Okay, these are the symptoms. Okay, cool. Let's look up the diagnostic criteria together. And then I'll go over it with the patient. I'm like, okay, so you have this, we don't have this, we don't have this. So we don't meet the criteria right now. Here are other things that I'm thinking about. And I'll go kind of over all the different things I'm thinking about. I'm like, okay, so back pain. So we want to rule out all the scary stuff. We want to make sure there's nothing else going on, and try to be really thorough. So unfortunately, and Charlotte, I'm sure you've encountered this in medicine, we just get so overburdened that it feels like you have to rush to do all the things. I know you have so much charting that nurses have to do. It's insane. And, primary care, they want us to see a patient every 15 or 20 minutes, which is insane to me. Like you can't do anything in 15 or 20 minutes. Like you half-assed, you're like quarter-assing it at that point. So a lot of that is the way healthcare is structured, which is so shitty. And the people who suffer are the patients and the physicians, because nobody is like, I'm going to be a doctor or nurse so that I can rush and provide terrible care. Yeah.
Right. And
Right.
that's unfortunately where the disconnect is. Like you're saying, now you've limited your time, that one-on-one interaction with your patient to just 15 or 20 minutes. You can only address so much. You have to at first address their initial complaint of the initial chief complaint of why they're there. And if they bring up another question, or if you notice something else in their chart and it's kind of like, well, I want to mention this, I'll strive and mention this just to get them in their mind. But then you only have so much time. And then you have others that need to be seen as well. And I think that's where the disconnect, when you were describing Dr. Snow, how you actually take the time to go through, okay, so what are you really feeling? Okay, let's go down this list of things to really see if you need that specialty referral. And I think that's where the frustration is. Patients want and know that, I WebMD this and I know I have this, so I need a specialty. And, too often, for the physicians I have worked with in the past and my other specialties I've worked in are become, yes, they're overburdened and frustrated at the same time to hear patients tell them how to do their job, understandably so. But, they don't, take the initiative or the time, or just generally don't care, unfortunately, to take that time to address specifically and try to zero in on what they really need or what their complaints are, and determine for themselves if it's really a need or if it's not, and it's something that can be handled. So I do see where you make a clear point in that, Dr. Snow, but oftentimes that's where the disconnect is.
And I'm not perfect. I've 100% rushed and been like, I really want to talk about this, but we can't right now. I'm so sorry. So, I've definitely am not perfect. But it's something that I'm definitely working on incorporating in my practice, because I feel like it's just a much better way. And then also, kind of going back to the whole trauma-informed care thing, it goes back to that patient autonomy. Like, the patients want some power back. They want to feel like they're in control of, they're like, I'm having these symptoms. I don't know what they are. Here's what my concerns are. And so they're trying to advocate for themselves, which is awesome. Mm-hmm. So a lot of it, I think, for healthcare is reframing. And this is something that I'm working on in my own practice is, the patient's they're not, bossy. They're not difficult. They're someone who is assertive. They're someone who knows what they want. They're someone who's concerned about their health, which is great because a lot of people don't give a fuck.
Mm-hmm. And I think really, part of it is control, as self-actualization, being able to sort of have a say over what happens to you, but also just like being heard. I think a lot of times people have the experience of going to a doctor or going to a healthcare provider and just having their concerns sort of dismissed or not listened to, or being told that it's all in their head, or blaming it on, like, in particular, like obesity, for example. Like, obesity doesn't cause every health issue. It can definitely raise the risk for some of them. It can be a factor, but I definitely have heard many, many, many stories of people who have gone to the doctor and being told whatever their issue is, that they just need to lose weight, just as an example. So I think just listening to a patient, if we're doing trauma-informed care, really what we're doing is we're listening. We're treating people with respect and compassion. And that's what everybody deserves, really.
Yeah, absolutely. It's very, very important for Dr. Snow's point is, if we want trauma-informed care, trauma-informed medical care and mental health care to kind of join together, our system is not set up to allow that. Because like what you're saying, you have to only have like 15 minutes with a patient. And I've had that experience. I have Hashimoto's disease, and it took a long time to get to the point where I could see. I brought up endocrinology because it was such a difficult thing for me. And even after it was like, okay, yeah, I'm seeing this. Don't worry, we'll treat that. But I wasn't given, there was no time to actually have a conversation. My doctor's hand was always on the door. That's what I saw. What I saw was, I am not really being heard or cared about. I'm just a checkbox, because he's coming in, he's doing this quickly, and his hand's on the door, and there's no time for me to ask those questions, which is why I'm like, I want to go see an endocrinologist because I'm not getting anything from you. Whereas I maybe could have had everything taken care of by him, but there's no time. There's no time for him or for me to feel that kind of care. So how can you be trauma informed? How can you give agency back to somebody? How can we address this if we're in a society, in a culture in the United States? We have a lot of people who watch from other countries, so I want to make that clear. In our country, in our culture, it is about the insurance companies and the bottom line. And you are meeting that. The medical care provider, the medical provider that we have at the Child Advocacy Center, she left her practice and came to us, even though it was a pay cut, because she said, here. She was doing it on her lunch breaks. She was coming in and doing this on her lunch breaks, taking care of kids. It boggles my mind. Taking pictures of kids' private parts, helping them through trauma on her lunch breaks, y'all. So she said, I want to feel like I have more impact and I'm making more of a difference. And now she could spend an hour with a client, with a child and their caregiver, not just dealing with why they're at the center, but dealing with all of these other things. She does a full well check, not just what brought them in. She does everything, and she gets their medical records, and she talks with the therapist, and she's doing all of this stuff. And she's like, I wouldn't care if I had to take another pay cut. This is what healthcare should be.
Mm-hmm. Absolutely. Yeah, I think that's something that practitioners, doctors, nurses, anyone who works in this field, that we really need to take ownership of this aspect of our patients' care, because we take care of their mental health, their physical health. But there's this kind of allegory where you're invited to imagine yourself stand on the edge of a river and you see all these baskets floating down the river with babies in them. So what do? Do you set up a camp on the edge of the river and gather these babies into the shore? Or do you go up the river and find out why babies are being put in the river in the first place? And so why aren't we as practitioners being more purposeful about really going up the river to find out why this is happening? And if the practitioner, and this is specifically mental health, we put so much pressure on the patient of, here are new coping mechanisms. How are you going to change your life? And that really can become neglectful. Certainly that is important, but it can be neglectful on our part as practitioners if we're only addressing it from that angle, because we're forgetting this entire ecological perspective of that we're not just individuals, we're part of the systems that we're born into. And so especially in a country like the United States operating under capitalism with these for-profit healthcare structures, when we see this disparity, it's the system working as it was intended to. And so no matter how many good coping skills we learn, the fact is that we live in this society that is designed to create disparity. So if we as health professionals and mental health practitioners are not going to go up the river and get involved in these systemic issues, we're not doing our jobs. We're just putting Band-Aids on problems.
Mm-hmm.
Standing ovation. Oh my God. Yes.
Hannah, you put the nail on the head.
Woo! That was like that should be totally taken and put into a soundboard or something. That was amazing. Yes. We have a few questions from the audience I want to go ahead and get. And one of them comes from ElectroLive. He says, can too much pleasure cause stress as well, like an imbalance that causes an unhealthy mental state? It's kind of an interesting question.
I mean, I guess that it sort of begs the question, what is too much? There's just so much, our society is so focused on the grind, right? Like, we got to be productive. We got to go to work. I think there's, for a lot of people, like, taking time to relax or vacation, it almost like they feel guilty about it a lot of the time. Like, it's almost stressful to try to relax. And so I don't know that I've ever seen anybody that had mental health issues because they relaxed too much, if that makes any sense. That's a very difficult question, because I've never encountered that. The only thing that I can think, like, there are addictions, right? You can be addicted to things that give you pleasure, like drugs or food or sex or whatever. So that can be unhealthy. But also I want to acknowledge that typically a person who is seeking out that is trying to fill or heal. They're trying to heal a hurt that was caused by something else. Usually it's trauma. But that's not actually what they're seeking. It's just what they're substituting. So again, it's not the thing that's causing the issue. Well, I mean, but with drugs, it's not helping anything for certain. But the original injury, the original hurt that never got a chance to heal. I don't know if any of you are familiar with Gabor Mate. He said something really phenomenal in this documentary, is that the trauma isn't that like we were harmed in childhood, is that we were left alone in the harm. Like we didn't have a chance to process it. We couldn't talk about it. It was dismissed. And that's where the real hurt comes. When you're,
yes, absolutely. Looking at trauma in children, that's so often because children are so resilient. In the lab that I work in, we do these studies that just shows the incredible resiliency of children, but so often where they develop the PTSD, the depression, the anxiety is where they don't have that support system. And we can look at things, what are the factors that we look for in a child who is resilient? And then we can see the opposite of that is, if this child is not having these aspects in their life, such as, a family support system, that they feel safe at home, that they have this overall sense of worth, they're not going to be able to achieve that resiliency. And so that's absolutely true that, you can experience a trauma. Some people can experience post-traumatic growth, and that's a relatively new field of study within positive psychology, is this post-traumatic growth, where we're seeing ways that people are able to achieve growth through trauma. But the way that our society is structured currently, and so often, especially with children, we see this dismissal because, for instance, the DSM-5 that we use in psychology as our diagnostic manual, which has a lot of issues in its own. And one of my particular issues I take with it is that it does not have special sections dedicated to pediatric disorders and pediatric symptoms. So we have a whole section on diagnosing depression, but it's for adults. And so we really often, children are overlooked in that sense. So a child may be experiencing those symptoms and we never give them the chance to experience post-traumatic growth because we don't acknowledge that they've been traumatized in the first place.
Absolutely. In fact, many of the disorders, they don't want to diagnose under a certain age. They don't even want to touch it. I mean, it's so frustrating. But you're exactly, go ahead.
Yeah, I'm just saying, then that sort of carries through to adulthood too. Like, how many adults experience trauma, whether in childhood or their adolescence or young adult, whatever, and they don't even recognize it in themselves as trauma because it was normalized, or they tried to talk to somebody about it and they were told they were overreacting or it was dismissed. I mean, I also think about, and not necessarily like, I think they have other terms for it too, but like people who are in our marginalized identities, whether racial or gender or sexual orientation, like Black people in particular have they've done studies that have shown that they're higher rates of a lot of those chronic diseases. And a lot of it's just due to the trauma of living in a racialized society and having to live with that every day. And I don't know that there's a lot of recognition in the medical community that that's a thing. I also like patients who have chronic pain or, or have to access the medical system frequently because they have medical conditions. I don't know. I just think of the conflation of, there is overlap, of course, between people with addiction issues and people with chronic pain issues. Like that's like the trifecta, right? The depression, chemical dependency, and chronic pain. And I really wish that we had like clinics that just like dealt with all three of those things together because they happen so often. But when you become familiar enough with a medical system that you like are asking specifically for medications that would work for you, a lot of times then that sort of now you're more likely to be labeled as drug seeking or and have your pain or whatever you're experiencing just completely dismissed.
Yes.
I wanted to touch back to what you had said about people who don't realize they have traumas. That is so prevalent. I feel like especially for women. I had a patient come to me for STI testing, and I was just pretty much anytime I do STI testing, I always check because there's so much assault that happens in the military. And I was like, so when was the last time you were sexually active? So long ago. Okay. male, female, both. What was kind of helped me understand what was going on. Well, I was with this guy and we're kind of dating, and he said he had a condom on, but then he didn't. And I was like, hold the phone. That's assault. And she just looked at me like, what? She's like, but I was okay with having sex. I was like, you're not okay with having unprotected sex. And I could just see in this patient's mind, like, oh my God, like, how normalized has that been?
Mm-hmm.
Mm-hmm. Yes, that's such a good point, where a lot of times people don't even realize what they experienced is trauma. And so I think we have so many people walking around this world who have been traumatized, who don't even know it. And so when you think, a doctor, a nurse, you're in the hospital, you're encountering these people, the chances, and we look at even just prevalence numbers, and those are the ones that we know, people who have reported a sexual assault case. And there are so many more people who we don't even know, and they don't even know are traumatized. So when you're in a healthcare setting, going back to trauma-informed care, part of that, I think, is just assuming that a lot of the people who you are going to encounter today, if not all of them in some capacity, have been traumatized. And so if you go into it with that mindset of we all, in a way, have our own version of a traumatic experience wherever it falls on the spectrum that we have gone through, you treat people with that different sense of kindness and compassion. And so I think that blanket approach really is critical to trauma-informed care, especially for somebody who's on the front lines, like a doctor, a family practitioner, a doctor, or a nurse.
Yeah, I think doing trauma-informed care with all patients has really revolutionized my practice. Charlotte, what do you think?
Oh, absolutely. I mean, I always want to make sure that my patients feel heard and feel believed and feel cared for. I don't know how many times I've had a patient like put their call light on and they're like, I'm so sorry for like needing things, basically is what they're apologizing for. And I'm like, never apologize for asking for help. Your needs are, they're like, I know you have a lot of other people to take care of. I'm like, your needs are also important. It's just, it doesn't take a lot, but it just takes usually a few minutes to like really help them feel heard and understood and cared for. And that's my aim with every patient.
One thing, there was a study that was really interesting that showed that if a doctor or a nurse sits while they talk to the patient will perceive them as being more caring and as having spent more time than they actually did.
Mm-hmm.
So kind of going back to trauma-informed care, sitting, so if I'm standing over you talking to you, that's going to be a very different vibe than if we're sitting and we're eye level or I'm below the patient. Our exam tables are these like really vintage, horrible ones. They don't adjust. So they're like, the kind where like you're an adult and you're swinging your legs off like you're a child. Like that's what I'm working with right now. So my little stool that I sit on is way down here. So I'm usually looking up, talking to folks. But I think that's good too, because that sort of reverses that power dynamic. Because I know in healthcare, definitely, I know there was a question about, a lot of people don't want to disclose that. So I tell folks, you don't have to tell me what happened, because I know that reliving can be really hard and explaining it. So like whenever I'm doing a well woman exam, I'll ask, has anyone ever hurt you? And just leave it at that. And if they say no, I say, okay, we'll move on. Sometimes I'm like, okay, well, we're going to dig into this further at another point. Or, sometimes like that, like asking what someone's experiences have been. It's that relationship building that our stinking healthcare system isn't built for.
Mm-hmm.
Mm-hmm.
I really wish our hospitals were set up a little better as far as that goes, because like they're in their hospital bed and my computer's up here mounted on the wall. Like I don't really have the option to sit down. And even if I were, like if I'm doing my assessment and I have to get it in the flow sheet, I've been trained, like I'm supposed to do it in the room. So like I'm with the patient and I go back and I put it on the computer and I got to click through the flow sheet and I have to stand because that's where it's mounted on the wall. So it's not super conducive to that. And we do ask, like there's suicide screens and there's abuse screens and whatever. And it's just like, but it's like in this battery of questions and it's not easy to it's not like you're not doing it in a casual conversational, like that it feels natural or that it feels like, I don't know, like this is the first time I'm meeting you. You've never seen me before. So has anybody ever abused you? It's not the best way to go about it, I don't think.
Yeah, I get. Hi, it's nice to meet you. I'm going to look in your vagina now. Hello.
Yeah. I think it's also one thing that Kathy's question kind of made me think, not just about being vocal about the trauma that they experienced, but just being vocal as a whole. Just being able to stand up and be your own personal advocate is often difficult in all aspects when you've been a victim of trauma. And I don't know if you guys have ever seen a patient who tends to seem really timid or uneasy, and that kind of gives you that red flag that maybe there's something more there, and they don't seem to, they're there for something, but they're not really giving you a lot, and it almost seems like they're afraid to even speak.
I really wish that we had like healthcare advocates, as in like somebody who actually goes to your appointment with you and helps, either backs you up so you can ask the questions, or ask, like you can discuss beforehand what you want to have discussed and how you want it to go. And if it's not going that way, they can kind of step in and be like, hey, can we get this addressed, or something like that? Because
Charlotte, all too often, and it's like it's upon the nurse to be the advocate, to be the cleaner, to do everything. And as much as we strive to and see the importance of that, and as much as we want to be advocates,
right,
it weighs on you.
And we're human too, we miss things. One of the things I like about working in a hospital is that there are many nurses coming into contact with that patient, so hopefully somebody catches everything, because certain people are going to notice things more than other people. But also, depending on the culture and depending on the physician too, it can be difficult to even advocate for a patient, because I've definitely been made requests on a patient's behalf and sort of been shut down by the provider.
Yeah. Yep.
Well, we're at the 1 hour mark, and I want to be very respectful for y'all's time, because you took the time to come on and talk about such an important issue. And so I'd like to get your final thoughts on trauma and healthcare. So, Hannah, I'd like to start with you. If you have any final comments or anything that you want to let the audience know is, the important kind of putting the nail on the head, so to speak, on this conversation.
Yes. I think I want to also speak to healthcare professionals. I think part of trauma-informed care for any healthcare professionals listening is taking care of yourself, just like Charlotte mentioned, because we so often are so focused on taking care of everyone around us that we forget that we can also be traumatized and experience this secondary trauma through these cases that we are working. So in therapy, we say therapists need to be in therapy. And if you're going to be a therapist, you better be staying in therapy yourself. And that applies to everyone. As far as the child angle, I think that we need to have respect for children. And in these situations, giving them the respect and the recognition as human beings, and remembering to give them that in these situations, and to treat everyone that we meet with this general respect. And anytime we go into a patient room and we encounter anyone in our life I see this meme, you be kind to everyone you meet, because you never know what they've gone through, and kind of just approaching life in general with that mindset that we should all be trauma informed, and approach just general life with this type of mindset would make the world a much better place.
Absolutely. I would love to have another show with you talking specifically on community resilience and childhood resilience and building resilient communities and all of that. I would absolutely love to have a show on that. And I know that's your specialty.
That sounds wonderful. I'm on board.
Absolutely. So Charlotte, what are your final thoughts on this topic?
Well, there's a quote by Brad mouth scars. Everyone you meet is fighting a battle you know nothing about. So be kind always. And I think that's good words to live by. You know, people want to be heard. They want to be seen. They want to be listened to. They want to feel like they matter. And if you can treat every person you come into contact with in that way, then you can't go wrong.
Secular amen. Absolutely. And Dr. Snow, your final thoughts?
Is this the part of the show where we say like praise Carl Sagan or something?
Absolutely.
I'm putting to the atheist pantheon. So if you're looking for a trauma-informed clinician, big things to look for are they listening to you? Are they getting consent? Are they explaining things? Are they moving not super fast? I listened to a really good, I think it was with Dr. Magda Gerber, and she said that her patients, the doors are really loud. And for people who've had any sort of battlefield trauma, that can be really hard. So just looking for people who listen to you, so that way you can be safe and kind of get that trauma treated. There is really good trauma treatments if you're someone who's experiencing, we have meds that we can help with the nightmares, the mood stuff, acupuncture. There's all sorts of different alternative and complementary strategies that work. And Hannah was totally right. Our system is functioning exactly how it was set up to do, which is completely fucked up. And we're all in this together. And I really love those quotes.
Excellent. Thank you so much. Jena, thank you so much for co-hosting with me tonight.
Thank you for having me, Sunny. I thoroughly enjoyed this. Thank you, all of you, for your input and for what you do professionally. It's needed.
Absolutely. So if you want to continue to see great content like this, be sure to like, subscribe, hit the bell, share, do all of those things because that makes a big difference. It helps with those algorithms. But if you want to support on a higher level, you can check out our Patreon and you can donate a little money here and there. Even $1 a month makes a big difference. It allows us to continue doing this important work. And we're not trying to just do the typical atheist content. We're trying to bring that level of knowledge and logic and experience that will actually benefit the world around us from a secular standpoint, but not, just looking at is there a God or not. We're trying to make a bigger impact, and we really hope that you're enjoying this type of content. So please consider subscribing, consider being a Patreon. I want to thank the people who are behind the scenes really making this work, like Wes, Josh, Phil, Kat, and Jena, who is like host on all kinds of things, and then she also does production behind the scenes. She is a powerhouse. I am telling you. She's amazing. Check out the other shows that are on the Patreon, the Promethean Secular Frontier, like Secular Soapbox. Women Atheist Unload is one of our newest shows, and I'm telling you, it's fantastic. Jena and I are also on that one, along with a couple other great hosts. We also have Sandbox Debates and One Good Reason. So check us all out, and please feel free to come back. And until next time, always remember to think critically. Good night, y'all.